So as you guys were talking, it was clear to me that you guys were talking about the cases you guys were talking about were extremely complicated, really difficult psychosocial medical cases. And you were talking about different kind of educational models where different kinds of providers would get different kinds of education. I'm going to focus a little bit more on, in collaborative care models, kind of more formally, on taking care of a larger number but of more kind of medium hard patients in a systematic way, and how education can actually come from the implementation of a model kind of almost by accident, but in a way that I think is good. I also, as I was sitting there thinking, I realized that I am probably nearly the last thing between you and the end of your day, so I'll try to keep it quick and light. So the goals for my talk are, briefly, I know Sanjeev already spoke some about collaborative care models in general. And I'll briefly review those just to kind of get to our main aims of talking about some different applications of collaborative care models. So one model talking, as David and Sanjeev have both talked about, sort of implementing collaborative care in inpatient settings, and also different kinds of collaborative care that you can do with people. Do you just focus on mental health? Do you try to focus on all of their different medical and psychiatric problems? And then toward the end of the talk, I'll actually try to talk a lot about nuts and bolts. These collaborative care models are actually kind of complicated to actually implement, and if there is a pretty good systematic approach that you can take to really make sure that you're getting the collaborative care model right. Because when you get it right, it's awesome. It really works. Patients like it, providers like it, but it's a lot of work up front to really get things kind of set in the right motion. All right, so why are we talking about this anyway? One of the biggest things that you guys all know and that we face as providers, whether we're medical physicians, whether we're psychiatrists, whether we're nurses, case managers, whoever we are, is that medical outcomes are so clearly influenced by mental health needs, mental health issues, and other kinds of psychosocial factors. And as one example, I thought I would talk a little bit about depression. So up here on the little gray area here is kind of the spectrum of illness that a person may go through, from being medically healthy to having a chronic medical condition to having some acute exacerbation of an illness. Maybe they have a heart attack because of their heart condition, or maybe they have a COPD flare, and then survival or mortality. And so what relationship does depression have with things across the spectrum? Well, first, depression is associated with the onset of new medical illness in people who were previously physically healthy. So in the cardiac literature, they've done studies where they've looked at people who were depressed in their 20s and 30s and found that they were more likely to get and to die from heart disease than patients who were not depressed in their 20s and 30s, independent of traditional risk factors, independent of family history, independent of age, socioeconomic status. Depression is really bad for your heart. For people who already have a medical illness, depression is associated with progression of the illness. So people who start hemodialysis, or people who are first diagnosed with hepatitis C, or people who have new diagnosis of COPD. People who are depressed and have been chronically depressed at the time of diagnosis actually have faster progression of their illness, actually have more hospitalizations, have worse outcomes. Again, independent of traditional risk factors. And furthermore, depression is associated with mortality in the context of a more acute event. So again, in the cardiac literature, if you have been depressed, if you are depressed at the time that you've had a myocardial infarction, a heart attack, you are twice as likely to be dead in a year than if you are not depressed after you've had a heart attack. So the difficult news and the difficult piece about this is depression and other mental health issues play a major role across the spectrum of medical illness. The good news is depression, anxiety, psychosocial distress are all things that we can influence, that we can modify, that we can treat. And so this isn't just something that's difficult to hear, it's actually something that we can do something about. Now, the current approaches, as you guys know, to challenging patients who have both medical and psychiatric needs aren't working as well as they could be. In the US, and I think in a lot of places, we have pretty siloed mental health care. So a patient will come and see their primary care doctor, and then if they are getting mental health care, they'll go to a psychiatrist, or they'll go to a social worker, or they might even go elsewhere in the community and see somebody. And this causes trouble for a number of reasons. First, there's a real lack of communication. Even if people are within the same system, the level of communication about the person's mental health needs and the person's medical needs is often relatively limited. Second, there aren't enough mental health practitioners to see patients individually one-on-one. With 15% of medical patients having current major depression, 15% times all of the medical patients in Canada equals a lot of practitioners, and individual mental health practitioners don't exist for the need. And furthermore, among those patients who need mental health care, a lot of people don't want to go see a social worker or a shrink or some other kind of crazy mental health practitioner. They don't like the stigma, they don't like the idea, they might not like being depressed, but they might not mind actually seeing somebody who helps them with those issues embedded within their own care. Similarly with educational or algorithm type interventions. Educational interventions in medical settings are great ideas and a great first step, but when they've been studied by themselves, don't do much to change primary care providers' behavior and don't do much to change patients' outcomes. Similarly, when medical providers are provided with screening tools and algorithms for treatment, not much happens. Sometimes the algorithms get followed, often the algorithms aren't enough. Patients with serious anxiety disorders or depression, they often require several steps of treatment. They often require therapy and medication, or several steps of medication treatment, and often algorithms aren't enough to really get people all the way better. So our current approaches, feel like a start. People are getting some care in the community. People are, sometimes getting more education of the medical field. But in general, we don't have the kinds of care that people really need to get all the way to remission of their mental health condition. So that's where these collaborative care models come in. As you guys have been talking about all day, and as I'm sure Sanjeev spoke about, these utilize a specific person, a depression care manager, who kind of rides shotgun with the patient through their depression. They help to identify the patients with their depression, and you can substitute anxiety disorder, you can substitute any kind of mental health issue, substance use disorder for depression as I'm talking. But the care manager helps to identify the condition, will do some education about the condition, and then get some expert help. We'll get help from a specialist, like a psychiatrist. The psychiatrist can make a specific recommendation about what to do, and then the care manager can help implement that where the patient lives in their medical care, in their medical home, in their primary care setting, or elsewhere. And then the care manager doesn't just do that one time, the care manager follows the patient. They either have in-person visits when the patient comes to their primary care doctor, or they call them on the phone, check in with them, how is treatment going, and so forth. And this lets patients get a lot for not doing a little, or for only doing a little. Patients are able to get really high quality depression treatment or substance use treatment or anxiety disorder treatment because they're getting specific psychiatrist recommendations who's been reviewing their case. At the same time, they're getting all of that treatment within their own medical home. They don't have to go to a separate appointment. They don't have to go elsewhere. They just have this nice case manager who's helping them and sort of helping them navigate the system. And furthermore, these patients are getting stepped care. So it's not just that they get started on Prozac or they get a few visits of psychotherapy. If things are going poorly, they get more until they're actually all the way better. And there are some very specific components that are really critical about these models. And unless you have these 4 components, these models don't work very well. If you have only 2 of the 4 or even 3 of the 4, often patients in these models don't really get better. First, you've got to find a way to systematically identify patients. If you just wait for somebody to refer patients, you're going to get only a very small proportion of who's out there who needs help. Second, you need a team, and you need all the members of a team. You need the ride and shotgun care manager, you need the expert psychiatrist, and you need a primary care provider or other medical provider who has bought into this, who's willing to accept recommendations from the care manager when the psychiatrist has made them, who is willing to kind of go along with this model of care and not just refer patients out. Because any medical provider's first instinct is that, well, this patient's having a mental health issue, they should go see some other mental health provider. And to actually get them on board with the idea that the patient's actually going to have their depression managed within this clinic does take some doing. Using some objective measures to identify and monitor symptoms over time. This is really important. Making sure that you have some system of some symptom measurement that patients are getting asked over and over and over. Having a general sense that a patient's doing well or not is useful, but really being able to quantify things and saying, okay, well, this person's PHQ-9 score is still X, we need to do something, ends up being really important in terms of actually getting patients well enough. And focusing on remission, focusing on not having patients get just a little bit better, but having patients get all the way better. And we all fall into this as practitioners. We all think, well, this person, they were recently homeless, they've lost their job, they're living with 6 family members, they had childhood trauma, and they're depressed, and they feel 10% better. That's great, that's amazing. Their life has been so hard, why would I expect anything more? In fact, even the most psychosocially complicated patients will often get into remission with 3 to 4 to 5 to 6 steps of treatment. But often you really have to really get down and focus that your goal is remission and really kind of doggedly pursue that, or else these patients will stay 10% better, which is nice, but not helpful for either their mental health, but also their medical outcomes. All right, so these collaborative care models sound good. Do they work? By and large, they do. They've now been studied in 24,000 patients. We don't need another collaborative care study. There's been 80 trials. There's been 24,000 patients. These things work relatively well. When they've studied these both short and long term, they have reasonably good effects, even though when in studies they actually compare these to pretty comprehensive control conditions. This isn't just that people don't get anything. Usually in the control condition, there's more notification of the patient, more notification of providers, and collaborative care still whomps these usual care paradigms, showing that these models actually do work well when you really have those 4 steps. And there are beneficial effects not just on people's depression, but also on their quality of life, on satisfaction, and other kinds of things. They also are really cost effective. And the interesting thing is, in the short term, they're pretty cost effective in the first 3 to 6 to 9 months of doing it. But what people have found, what Wayne Caton really found, who is kind of the person who's done the most work in collaborative care, is he always said the longer you can measure, the more cost effectiveness you'll see. And that was very much true in all of his studies. In one of his big trials, the IMPACT trial, they saw that the IMPACT collaborative care intervention was pretty cost effective in the first year. It was only a year study. But then at year 2, it was actually way more cost effective. And by year 4, it was actually cost saving. It turns out that people often need to get their mental health sort of affairs in order before they actually start to see reduction of readmissions. They start to see less healthcare utilization. They start to see fewer cardiac symptoms or other kinds of medical symptoms. And so it's interesting that there's more of a sequential approach to how patients recover, which I think is really important and actually shows that even a targeted intervention for a certain amount of time can actually have long-term effects. All right, so studies are nice. Does this work in the real world? There have now been numerous studies of real-world implementation of these things. Linda Gritma studied them out in California. There have been a couple studies out in Washington. There's a 4,000-patient study in the UK. And when these are implemented very carefully with our 4 steps, with good training of physicians, care managers, rates of depression remission are actually just as good as they are in research studies. And there are now tons of available guidance, especially on available websites from Washington, about how to implement these things really well. Okay, so collaborative care in general works. You have a primary care or other medical setting where you have a group of patients who have something identified, say depression. They have a care manager who follows them. They have a psychiatrist who helps out. They have a group of physicians who are willing to be on board with this. It helps people feel better. It helps people have better quality of life. It helps people's function. Those things work relatively well. What about ways to actually boost collaborative care? Are there either populations of patients for whom it's even more important to do good depression and medical care, or are there other ways in which we can use collaborative care to even more benefit? So one possibility, one that we've been particularly interested in, is inpatient initiation of collaborative care. So why would you start collaborative care in the hospital? Well, first, it's a really important population, right? Inpatients are the group of patients who end up dying. They're the ones who get readmitted. They use a lot of health care. They end up having a lot of adverse events. So if you can actually affect mental health outcomes and therefore medical outcomes in this group of people, you could get a lot of bang for your buck. Furthermore, the connection between mental health and medical health is the strongest in this group of patients, among patients who've had an acute medical event. We know the most about the connection, and the connection seems to be at least as strong, if not stronger, than in other populations. Furthermore, when people are in the hospital, they're often a little bit more motivated to make change. It's sometimes what we call a teachable moment. People have just had some major medical event, and this may be the time when they're willing to talk to a counselor, change their health behaviors, take a medication, something maybe they weren't willing to do before, but now they've really seen an abrupt consequence of maybe not taking care of themselves the way that they should be. Furthermore, a good reason to initiate collaborative care in the hospital is it's a great location. It allows, when we've initiated collaborative care, it allows our care manager to spend lots of time with the patient while they're in the hospital. Instead of just having a half-an-hour initial appointment, she can go back 1, 2, 3, 4 times while they're still in the hospital to meet them, to talk through things with them, to do some education. They can really build an alliance in the hospital. It also, if you initiate treatment, it's a great place to allow for monitoring of side effects. Usually people have side effects that make them stop psychiatric treatment in the first 2 or 3 days. If you're initiating in the hospital, you can actually watch the patient over those first 2 or 3 days, help to manage side effects in the first 2 or 3 days, and keep them from stopping their medication often for good in the first 2 or 3 days. And the flip side of that is often if you don't intervene in the hospital, they often won't be seen by a medical provider, sometimes for weeks or months, until you've missed a big opportunity. You have a depressed person, say, who's just had a heart attack. They're really willing to make change, but now 3 months are going to go by until you have another swing. All of this led to us initiating a trial. We decided to give this a try. All of this stuff about inpatient initiation of collaborative care sounded good, so we thought we would actually try to implement it on our cardiac floors at Mass General Hospital to see if it was actually useful. This came from our initial work. We did some studies on the cardiac units and found that frontline providers, nurse practitioners, residents, were not very good at identifying their depressed cardiac patients, which isn't surprising. Patients now come in for a heart attack. It's like a 2-day thing. They're lying in bed, the elephant's sitting on their chest. They go in an ambulance, they go to the cardiac cath lab, they come back, they get some aspirin, they get some beta blocker, they get an ACE inhibitor, they get a little bit of education, they're out the door. It's literally a 48-hour process. To expect that frontline clinicians are suddenly going to start recognizing depression and initiating treatment in literally thousands of patients a year is not realistic, but it's still an important problem that needs to be addressed by someone. What we did find was that asking people 1 to 2 questions about depression was incredibly effective in this setting. Even in medically ill patients, if you ask patients, for example, have you felt depressed much of the time in the past 2 weeks? If somebody said yes to that, there was a 50% chance they had a major depressive episode lasting at least a month prior to the hospitalization. If they said no to that, there was a 2% chance. 1 question. And so we really found that though asking frontline clinicians to do a ton of work with depression was not realistic, maybe having them ask 1 to 2 questions might be feasible if we could do the work on the back end. So what we did was we initiated kind of a standard collaborative care model, except we did it in the inpatient unit. So we initiated PHQ-2, 2-item screening, as part of the nursing intake interview. We actually got a sticker. They had this cardboard foldouts that they asked at every intake interview on the cardiac units. We actually got a sticker and put literally thousands of stickers with the PHQ-2 into those foldouts, and literally 6,000 patients got asked the PHQ-2. When a patient had a positive PHQ-2, our care manager, who was a social worker, she would go and ask the patient more questions. She would do a PHQ-9 to ask about the symptoms of major depression, ask about a few rule-out conditions, and would identify patients who had serious major depression that had preceded the hospitalization for at least a month. Then, for patients who enrolled in the project who are randomized to collaborative care, she would do some education with the patient. She would talk to the psychiatrist, usually me. We would come up with a plan. Start Zoloft, or that the care manager was going to start doing some kind of therapeutic intervention with the patient. Would give the cardiac folks a letter saying, we've reviewed this patient, Dr. Huffman recommends 50 milligrams of Zoloft. We would call the patient's PCP, and we would try to get treatment initiated in the hospital. This was really important because if we could just get that first prescription added by the time they were discharged, it became part of their med list. It actually became part of what happened. If we missed that opportunity, it was too hard to catch people falling through the cracks. Then the care manager would follow the patient for the next 12 weeks just by phone. The patient never came back in, but the care manager would follow the patient by phone, do PHQ-9, check in about how's the treatment going, if they were taking medication, are you having any side effects? If the patient was doing worse, they'd get more recommendations from me. We would try to coordinate them with the PCP. If the patient was doing great, then great. We were able ultimately to enroll 175 people in the project. 85 got usual care, 90 got collaborative care. And over 12 weeks, we found that people who were randomized to collaborative care had greater improvements of depression, quality of life, anxiety. And we saw something really interesting. At 6 months, 3 months after the intervention was over, patients in collaborative care actually had fewer and less severe cardiac symptoms. They were more likely to be adherent to diet, exercise, and medications than people who were just randomized to usual care, even after the intervention was over. We did not, however, have any impact on our hoped-for goal, which was cardiac readmissions. And so we looked to see, well, what were the things that made people not respond to our little collaborative care intervention in the hospital? And what we found was that high levels of anxiety at enrollment, which we didn't intervene upon at all in the Succeed study, were associated with non-response to the collaborative care intervention at 6 months. And so following that, we then tried a new approach to collaborative care. We developed the same model, inpatient collaborative care, identify patients in the hospital, social work care manager coordinates with me or another psychiatrist. We follow them by phone. But this time we identified patients with depression or generalized anxiety disorder or panic disorder, depression or anxiety disorders, to see if simultaneously managing those would actually help people get even more better. We also intervened for 24 weeks, and we trained our care manager in cognitive behavior therapy to give her an extra tool. So she would be able not only to make recommendations and provide support, but she could actually provide an evidence-based treatment. So in the Mosaic trial, as we called it, we randomized 183 people, and we had, again, improvements in health-related quality of life, depression, function, and a whole variety of other outcomes at 24 weeks, which was great because this was an even more complicated population because these patients often had more than one psychiatric condition at once. The other thing that was really important about our interventions, or that we really wanted to be important about our interventions, was that we wanted them to be as pragmatic as possible. So, for example, on our cardiac units, we took patients who had an MI or unstable angina or an arrhythmia or heart failure, basically almost all of the cardiac patients. And not only did we take patients with depression or anxiety disorders, we had very few rule-outs. We took patients with functional limitations, we took patients with personality disorders, because in the real world, these patients would be part of care management programs. You wouldn't exclude somebody because they had a personality disorder or because they were functionally limited. And so we tried to make this as real life as possible. Now, what we weren't able to do, we did not see between group differences at 6 months in cardiac readmissions in the collaborative care group, but we did see a couple things. Among those people who were readmitted, patients randomized to collaborative care took a month longer to get readmitted. And at a couple of critical time points, like 60 days and 90 days post-admission, people who were randomized to collaborative care actually did have lower rates of cardiac readmissions, suggesting that this sort of integrated mental health treatment may not have entirely avoided cardiac readmissions, but it may have slowed them to some degree. So in some ways, this was good. We were able to develop kind of a newer model of integrated care where we actually took the highest yield, highest complexity medical patients, and we were able to treat a bunch of psychiatric conditions in patients with a broad range of cardiac illnesses using just a half-time social worker and a part-time psychiatrist. And we found some pretty good outcomes in terms of both mental health and function. At the same time, we didn't hit kind of the holy grail of reducing cardiac readmissions at 24 weeks as we'd hoped. And we've started to think even more about what we could do better. And that might involve a more extended collaborative care model, larger groups of patients that we intervene upon, or something called a blended care management model. So blended care management models is a different kind of innovation of collaborative care. So in the blended care model, what happens is something different than classic collaborative care. So in classic collaborative care, you have your depression care manager and you have your depression treatment, and it's all happening kind of over here. Now, a lot of times, there are chronic conditions that are starting to have their own care managers. In the U.S., heart failure care managers are very common. You'll have a nurse care manager who's calling the patient, who sometimes they'll do vital signs remotely. They'll do all sorts of things with the patient. But all of a sudden, now you've got your depression care manager, and you've got your heart failure care manager, and maybe you'd have a COPD care manager, and all of a sudden you have like 50 care managers, and you're the poor patient, you pick up the phone, and you don't know who it's going to be. Why not, instead of having 80 different care managers for one patient, why not have one care manager who's actually co-managing all of these things? And so in blended care management program, the most famous of which is called Team Care, which was done out in the state of Washington, they train nurse care managers to focus both on mental health outcomes, but also specific medical targets. Things like blood pressure, things like weight, things like blood glucose. And the care managers actually would focus on 3 aspects. They would focus on how's your, say, depression doing, how is your blood pressure and weight doing, and then they would actually do a little bit of counseling / motivational stuff around self-care, helping people to become more active or follow a healthier diet. So the care manager actually had an expanded role, but it was also a much more direct, like, let's intervene on these medical outcomes kind of role in complicated patients. And so what they did is they enrolled a couple hundred patients, either with poorly controlled diabetes or with coronary heart disease, and they did this intervention for 12 months. And as I said, they combined support for self-care, the motivational stuff, with specific interventions for depression, high glucose, high blood pressure, high lipids. They actually had some in-person visits. Because this was a primary care intervention, the patients would come in every 2 to 3 weeks to see their PCP who were enrolled in the program. And every time they would see their care manager who would check in on their depression and their medical illness and their self-care. And they had very specific treatment protocols for each of the conditions so that the nurses felt pretty comfortable in sort of handling whatever came. Algorithms, as we discussed, aren't the only thing, but often a systematic approach to initiating treatment was a very good start. And then they could get help from the psychiatrist expert on the team. And they also had a couple of other experts on the team. They had a diabetologist and a primary care physician. And so the backup band for the care manager became a little bit bigger. And what they found, there's a bunch of numbers on the slide. What they found, long story short, was that they improved depression, but they also improved people's hemoglobin A1C. They improved people's cholesterol. They improved people's blood pressure. And a really interesting part of this is when they did the blended care management model, they actually improved their depression more than regular old depression care management models. It turns out that when people were intervening on all of these targets, their depression actually got better than if they just had a siloed depression care manager. So collaborative care works relatively well. There are different ways you can use collaborative care. You can do a classic depression or anxiety disorder model in the primary care setting. You can initiate it in higher yield patients inpatient. Or you can try a blended care management model where you actually have a care manager intervening on multiple targets at once. It sounds like a good idea, and it is a good idea to do collaborative care, but it's also incredibly complicated. You're actually you're creating new roles for people. Psychiatrists have to act differently, care managers have to think differently, primary care doctors have to have different kinds of management of their patients, and there's a very systematic and structured and somewhat laborious process to actually get this started. And so now I'm going to talk a little bit about things that we've learned along the way about how to actually practically implement some of these models. So to start, you need to have buy-in from leadership. And this ends up being important for a number of reasons. So first of all, you have to have somebody to give you permission to do the thing. That's important. The other piece is, the financial piece is so critical. We're in the US, and I know even here in Canada, there's such a fee-for-service model, like see patient, get paid. And if you are working under that model, collaborative care doesn't make a ton of sense. I saw almost none of those patients in the Succeed or Mosaic trials, yet I was helping to manage them. It's an entirely different paradigm of care, and it's one that has different kinds of financial structuring that's necessary, and you need somebody to give that the green light. And so to come up with, to find a person who's a leader, who's willing to take this on, you have to do some really good education. Fortunately, there are some very good websites that have excellent advocacy information about how important a problem this is, how much this improves outcomes, how cost effective this can be. You can identify relevant recommendations. So in the US, a recommendation from one of the major preventative task forces just recommended that all patients get screened for depression. And hospital administrators know that Medicare in the US is going to start putting people's feet to the fire around this. And hospital administrators probably don't have any great idea about how they're logistically going to implement this thing. And if you can come in there and say, not only are we going to screen your patients for depression, but we're actually going to do something to make them better, because if you just screen people for depression, it doesn't help at all, as it turns out. That actually is something that can get people's attention. You can present examples of successful implementation elsewhere. That you aren't the first people to ever to try collaborative care. This isn't some weird radical experiment. This is actually something that's been studied in 24,000 research patients and now at least that many sort of clinical patients. Identifying gaps in clinical care service needs is really important. What is the hospital's problem right now? What's the administration's problem right now? Often it has to do with mental health and medical health. Some kind of integration of those patients who have those kinds of integrated problems cost a lot of money, have a lot of trouble, drive the providers crazy. They need help. And I think this is a kind of model that can get those people help. And so if you really want to start with sort of securing buy-in from leadership, because you have to have somebody to really green light the idea that some kind of model of this might work. Once somebody says, okay, go ahead, I'll give you some money to do a pilot project, or we're going to try this for a few months, or let me think about it some more, but come up to me with a good proposal. Then you need the right team. So there's really three pieces of the mental health team that you need in a collaborative care model. First, you need a psychiatrist. And the psychiatrist doesn't, in psychiatry, a lot of us, psychiatrists, are kind of introverts. We spend time with our patients. We go from patient to patient. We don't end up interfacing a lot with our medical colleagues necessarily. And in contrast, the psychiatrist really has to be the face of collaborative care. They have to be a very good communicator. They often have to convince whether it's nursing staff on an inpatient unit, or a primary care doctor who doesn't want to implement one of the recommendations, or some administrator, or anyone else, that this is a good idea. They have to be comfortable with this model and willing to supervise care managers. They have to be people in academic settings are often good at this because they're used to this idea of supervision and kind of one-step removed care, but it's very disconcerting for people who have been providing direct care for 10 or 20 or 30 years. And a comfort with medical psychiatry is really helpful. These patients will inevitably have some kind of medical problem, and having a psychiatrist who's comfortable with prescribing medications, with making diagnoses in the context of medical illness is really important. Your care manager. The care manager is really the bread and butter of the whole program. If you have a great care manager, you are in really good shape. If you have a care manager who's iffy about the model, or doesn't feel as invested in it, it can make things very difficult. And good care managers are not only really savvy about mental health, and good with communication, but also have to be very comfortable. They're going to be going up to physicians and saying, hey, we think it's important that this patient start Zoloft, or hey, Dr. So-and-so recommends this thing. And, they have to be fairly brave, because they're going to get some blowback from doctors. Doctors are going to be like, who are you, telling me what I should be doing for my patient? And to actually have somebody who's both brave enough and sophisticated enough to have those conversations ends up being really important. And they also have to be comfortable following a standardized protocol. Collaborative care is flexible in many ways, but there's a fairly specific way in which care is delivered. And often what you need, which doesn't come to mind immediately, but if you have a reasonably large program, you need someone on the back end to be helping you. Because one of the things that you'll do as part of collaborative care, so the care manager's off identifying patients, and then is on the phone or in person talking to these patients. But while all of this is going on, she's accruing lists of patients, and she's assessing people's, say, depression scores. And at weekly team meetings, which end up being the bedrock of the whole thing, somebody's got to be putting all of this information together. And if you don't have some way of systematically keeping track of every single patient and every single assessment for every single patient, patients are going to fall through the cracks, depression is going to get worse, somebody's going to be forgotten about, and you're going to kind of lose your grip on the patients and on the model. And so actually have at least a small part of an administrative person who's willing to kind of ride shotgun and sort of keep all of those things structured and correct ends up making a big difference. And training programs could be a big help, I put here. I mean, this is a very different way of doing things. There are some very specific training needs and educational needs that are needed. I'm going to talk about that in a minute. But actually having a program that trains people how to be collaborative care psychiatrists, physicians, care managers, administrators, actually could play a gigantic role in you doing well, because all of this sounds each of the individual parts sounds easy, but when you put it all together, there's actually a lot of training that's required. So somebody said, go ahead and do this, and now you've got your posse. You've got a team, you've got a psychiatrist, you've got a collaborative or care manager, you've got an administrative person. Now you need to figure out who you're going to treat. And initially, you're going to be very pushed to treat everybody. We're going to take care of everybody. There are so many needs, and we'll find all the patients who have psychosocial problems. You don't want to do that. What you want to do is you want to start simple, and you want to start with something that's relatively straightforward, or something that's well known. Depression is a good thing to start with. If you just identify depressed patients, your roster will fill up really fast. There's no problem in getting a group of patients who are depressed in medical settings. But this way, it gives you some kind of homogeneity of the kinds of patients you're taking care of and the kinds of interventions that are getting recommended. Because the kind of secret sauce of the education about this, and we were talking about this earlier, is that the first time you have a depressed patient in your collaborative care model, your care manager will go to the PCP and say, we're recommending starting sertraline, 50 milligrams a day, or citalopram, 20 milligrams a day. And then the primary care doctor will say, well, what are we doing that for? And then the care manager will describe it, and he'll say, okay, sounds fine. And then the second time, she'll come to him and she'll say, well, we'd like to start sertraline again, and he says, fine. And then the third time she comes, he'll say, I know, you're going to start sertraline. And so all of a sudden, the primary care doctor doesn't need that direction anymore. And that happens in a million different ways with a million different kinds of interventions. Maybe the care manager is talking about an insurance need for the patient, or some kind of other service need for the patient, or if it's a different kind of pharmacologic intervention. But basically what the care manager is doing is she's secretly educating the medical providers about how to manage common mental health conditions. And so even though this isn't an educational intervention, doctors who are a part of this actually become fairly sophisticated in managing most mental health conditions, thanks to the care manager. So start with something simple. Start with something where the care manager can educate the provider, and also decide right up front who's not going to be offered the program. Now, you guys were talking about complicated patients when I got in here, about patients with schizophrenia and those kinds of things. And while those patients definitely need sort of comprehensive, complex, and sophisticated treatment, these, sort of an initial model of collaborative care, you probably don't want to start there first, because you're going to have, especially if you have this idea, this model where patients are getting all of their care within the primary care clinic, you want to start with something that's a little bit more bread and butter. And so we've often not provided to people with bipolar disorder, with active and serious substance use. We will take patients who have some substance use. With cognitive disorders or very serious medical conditions, just to, again, get a group of people where we feel like if we're only following them by phone and they're only getting care in their primary care setting, it's not going to be a disaster. Determining how you'll identify patients. So we recommend some kind of screening. You can be, referral is another option, but most of the primary care doctors will only refer patients who are often crying out or asking for mental health care, and often those patients are already getting a lot of mental health care. But if you're actually doing systematic screening, you'll identify more patients, and you'll identify those patients who were more quietly depressed or anxious or having some other problem. And you really need to think through the logistics of this. Who's going to screen how are you going to screen the patient? Who's going to screen the patient? And then who's going to follow up on those screens? If you're getting every patient in the primary care practice screened, how are you going to have somebody to follow up on that? Often it's the care manager. The care manager has to be aware of positive screens in some way, and you have to figure out a system very quickly so that the system doesn't get overwhelmed. And then once you've screened the person, then you have to decide whether the person actually has a diagnosis. You need to train the care manager really well to assess patients for whatever disorder it is. And in certain situations, you have to become even more sophisticated. So in the inpatient setting, we had this problem all the time. If you just used a PHQ-9, one of these 9-item scales, to ask about depression for a patient who just had a heart attack, say, they would all be positive, because on the PHQ-9 you have energy, you have sleep, you have appetite, you have concentration. In the hospital, nobody's sleeping. Everybody feels lousy. They can't concentrate. They have no appetite. All of a sudden you're racking up points and everybody's depressed. And so we actually had to modify our scale. So we were talking about pre-hospitalization, talking a lot about the cognitive symptoms of depression, like depressed mood and anhedonia. And so for whatever population you're using, you have to make sure that your method of diagnosis is the right one. And then you have to figure out what treatment. So you figured out, okay, now we've gotten the go-ahead, we've got the team, we've got the setting, we're screening people. Now what are you going to do with them? And so you can get recommendations for treatment and get that prescribed to the primary care doctors or the other doctors in whatever setting. What about the care managers? Are you going to train them in just providing support, or are you going to provide them training in like problem-solving therapy, which is a empirically validated but relatively straightforward to implement kind of treatment? Some programs have this thing called watchful waiting, where people will have kind of milder to more moderate depression, and they will just sort of keep an eye on them for a little while, maybe for 2 months or 3 months or 6 months. And if things worsen, they'll intervene, and if they get better on their own, they'll do nothing. If you're going to do that, you want to think about the details. That has pros and cons. It becomes complicated because now you're like watchfully waiting this person, but you're not actively intervening. and they can fall through the cracks. On the other hand, if you have only a certain number of care manager hours, it allows you to only intervene on the patients who are most severely ill with a mental health condition. And then for patients who become sort of more serious, they either don't get any better with your treatment or they start to get worse, you have to figure out about what to do. Are you going to refer them? Is a psychiatrist actually, is the collaborative care psychiatrist actually going to see them? You need to think that through as well. So it's not just the treatment components, the first step treatment components where the psychiatrist is making recommendations. You also need to think about, okay, if nothing's getting any better, what would our next step be from there? And let's make sure I have this. Yep. So then finally, you need to set up some procedures for monitoring symptoms. So as I talked about earlier, you have your care manager who's going out and identifying these patients and calling them on the phone. But what you really need to do is you need to have a meeting every single week to talk about these patients, where you talk about every single new patient, you talk about every single patient who's doing worse, and you talk about any other patients who sort of come up that have clinical issues. And so you need to have some kind of way of sort of keeping track of people's symptoms. And to keep track of people's symptoms, the first thing you have to do is you have to ask people about their symptoms. So at every care manager contact, they do a PHQ-9. That way they can record the score of the patient went from a 14 to a 12 to an 8 to a 6. Or they went from a 14 to a 12 to an 8 and now they're back at 20. Something happened. Then at the team meeting, you'll be able to look. You'll have a little spreadsheet or some other thing that says, okay, that person's doing fine, that person, oh boy, that person's a 20 now. You'll have actually some way of quantifying who you need to talk about because you only have a limited amount of time. You can only talk about so many patients, and having some kind of structured symptom monitoring ends up being really important. And just as structured symptom monitoring is important, making sure that the contexts are really structured is important as well. Checking in, doing a structured assessment, asking about symptoms, doing some kind of education. Patients get used to this and like it, but if things just become an unstructured conversation, then patients won't get what they need and you won't be able to get your information. All right, now, one of the biggest issues about this is, this all sounds like a good idea to us, and maybe you even get the primary care docs on board, and you get the psychiatrists on board, and you figure out what you want to treat, but there's the patient. The patient actually has to agree to this. And so how do we talk about collaborative care to the patient? And I think the things that have been most successful to us is to really pitch this in terms of people's overall health. We aren't a group of people who are, trying to get in other people's business, which is what some people worry about, or that they're going to stigmatize them by calling them crazy or referring them out to some psychiatric clinic. We're here because, we're here to improve your quality of life, your function, and your health. And that's truly what collaborative care is all about. One of the big selling points also, and so we sort of talk about it as, this is a program focused on sort of well-being, quality of life, function, and making sure that you're getting the treatment you need here at the primary care clinic. One of the big pieces that's really nice about the collaborative care model is there's tons of leeway for collaborative decision making. Because the care manager gets to know patients so well, he or she is talking to them all the time. Patients get a lot of say in their treatment, even more say sometimes than when they're individually seeing a mental health care provider. Oftentimes, if a psychiatrist is seeing people for quick 15-minute med visits, there may not be a lot of time for collaborative decision making, especially if those visits are once every 3 months. There usually needs to be a decision made relatively quickly because not much is going to happen in the next few months. With the care manager can talk with the patient about what they're interested in, what the pros and cons are, and patients really like the idea of getting to choose their own kinds of treatment. They get to choose whether they're getting therapy or medication. They'll get to talk with the care manager in a little bit more detail about what it means to be on medication and maybe how long they need to be on it. Patients really like that the team is embedded within their existing medical providers. We usually say that over and over and over because that's a real selling point of this program. Patients are used to going to their PCPs. They're used to going to their medical providers. They don't want to stop going to their medical providers, and frankly, they don't really want to go to anybody else. And so making sure that they know that this is all part of their existing medical providers, and then in fact, their doctor is going to be the one prescribing the medications. Still, there are challenges. There are patients who don't want medication, and there are patients who don't even follow up with the calls and appointments. And you want to really kind of think through those issues. Our care managers have really often gotten quite good at sort of talking through things about medication, learning about people's fears about medication, that they might get addicted to antidepressants, or that they might be using it as a crutch. And they've gotten pretty creative and good about helping patients get into care who have been non-adherent with calls or appointments. You have to be flexible. This is a complicated population, and so figuring out some strategy to use with calls and appointments can be helpful. And it's a great way to use team meetings. You can say, oh, Mrs. Jones, she was going right along with the calls, and then all of a sudden her sister got ill and she stopped picking up the calls, or she says she's always busy. What are some ways that we might address this? And so people might have some ideas. All right, I want to talk about this. So as you can see, I feel like I'm kind of killing you with details here, but this is, these are kind of all of the little steps that can go to making your collaborative care program so successful. And what I think is really necessary, and I think if we had to do it all over again, what we would do is we would actually develop some kind of training program, some kind of education and training program. Because care managers, your poor care manager who's kind of out in the wilderness, he or she's with patients, is having to try to convince primary care doctors, is trying to make the right diagnosis, is trying to provide therapy over the phone or in person. Care managers need a lot of specific training. Education about the specific condition. If it's depression, how do you diagnose depression? What's the difference between depression and adjustment disorder, or depression and bipolar disorder? If somebody's suicidal, this comes up a lot. Fortunately, people being suicidal doesn't come up a lot, but worries about people being suicidal comes up a lot, and you need to have a plan. You're talking to your depressed patient over the phone, and they say, I feel like I don't want to go on living. Or even more, they say, I'm thinking about killing myself. What do you do? And having the care manager actually have some kind of structured assessment, and we actually have like a printed out assessment, a very algorithmic assessment that's like, if patient says this, ask this. If patient says this, ask this. If they say this, call Jeff. If they say this, email this person. And so having some kind of structured assessment that they feel comfortable with ends up being really important. Teaching the care managers, even though the care manager may not be a prescriber, they're going to get tons of questions from the patients about medication treatments and potential side effects, and they need to be able to speak at least in educated generalities. They're always going to say, we should talk, we can have you talk more to your primary care doctor about that specific question, but should always be able to speak at least in educated generalities about them. Do people get addicted to Zoloft? Or, if I start on Zoloft today, do I have to be on it for the rest of my life? Questions like that. And then if you decide to have your care manager get trained in something, you need to provide them training. If they're going to do cognitive behavior therapy, if they're going to do motivational interviewing, if they're going to do problem-solving therapy, you need to get them specific training. In addition to these content-specific things, they also need education in the model and the protocol. This isn't usual care. Actually, asking, I think most practitioners don't ask a PHQ-9 at the start of every session every time a patient walks in the room. Following a structured protocol, a structured schedule of assessments is new and different and important to remember. Learning how and when to reach out for help in this and who they can come to for help, and learning how to use this supervision in team meetings. And we'll often have these team meetings to run through patients, but sometimes we'll actually have separate supervision, especially if our care managers are providing psychotherapy. They'll actually have a separate meeting to go through the psychotherapeutic interventions. Likewise, psychiatrists also need training. If they're not psychosomatic medicine doctors, sometimes they need training in the medical psychiatry aspects of things, and training specifically, again, in the model and the protocol. In, how do you follow this protocol? What am I supposed to be doing with the care managers? What do I do if the care manager calls me? How much should I be stepping in? How much should I be advising? What is my role as a leader? All of these things are not part of the dyadic fee-for-service model that we've all gotten used to, and so psychiatrists need training as well. Skip that one for now. The other thing that ends up being really important is, even if you've got leadership that says it's okay to do this. Even if you've got a clinic where you can get it done, you've got a good team, you've got them all trained up, you need to also make sure that you're not just given the allowance to do it, but you also have basic infrastructure in place. For example, your care manager needs access to office space, phones, computers, a quiet space to do psychotherapeutic interventions, either in person or by phone. You want this space to actually be physically located, ideally near the psychiatrist and or the medical site. And you want to have a set of standard operating procedures. You're not going to be able to think of everything on the fly, and the psychiatrist is not going to be able to think of everything on the fly about what's done in usual circumstances. And these manuals can have things like scripts that care providers can follow if somebody's suicidal, or to talk about medications, or to help sort of engage them in treatment. And they can be incredibly helpful in helping people know what to say at just the right time, or know what threshold to take to for example, contact the psychiatrist. And it's often very helpful. We found it incredibly helpful to develop written information. We ended up writing so many letters to these cardiac doctors that we ultimately decided to template the letters. We ended up doing so many educational in-services for staff. We now have, templated educational materials. We ended up doing so much psychoeducation with patients, et cetera, et cetera. You end up doing all of these things over and over, and we learned pretty quickly that if we developed a binder where we've got, here's the stuff that goes to the doctor, here's some stuff we can use with patients, here's some stuff that we use as part of our own internal processes, it becomes incredibly helpful. So those are all the steps of starting collaborative care. It sounds simple, right? But if you're able to do all of these things, this isn't something you do over a night. This is not a sprint. This is a marathon. But if you're actually able to get all of these things in place, you will be amazed at what happens. You go from having the occasional patient in whatever medical center you're in identified as depressed, and then they get sent off somewhere and they do or don't get better, to actually systematically identifying a mental health disorder in a large number of patients. You get a care manager who becomes the leader of taking care of a whole group of patients. You see them really start to improve, and you don't just feel that they start to improve. You have a friggin' spreadsheet that's showing them improving. And over time, the medical providers become not resistant, but actually often really quite grateful about this as they start to see the care manager over and over, and see their patients get engaged with the care manager, and see people starting to do better. It can really be very motivating to see this work well. Now, if you're going to do this inpatient, there's a couple other things to consider. So the inpatient, as we discussed, has some real advantages. Not only is it a high-yield cohort of people, but also it's really easy to do the screening. As I said, nurses, when patients are admitted to the hospital, nurses have to ask them about 62 million questions about their diet, their allergies, their past medical history, their favorite flavor of pizza, whatever they have to ask them. The thing goes on for like half an hour. If you can add 1 or 2 screening questions to that, you've got an entry into getting these patients identified with a major mental health disorder. These patients almost never get treatment of their depression. Maybe if they're agitated or delirious, they'll get seen, but run-of-the-mill depression won't get treated, despite the fact that depression in just about every medical condition is a major risk factor for mortality in the next year or couple of years. Depression is very low on everyone's list because they have so many other fish to fry. You can actually bring this up by having somebody who can do something about it. And again, as we discussed, it gives people lots of time. However, starting inpatient collaborative care is not easy. The problem of people having a lot of physical symptoms means that you have to get yourself and your care manager very sophisticated about making the right diagnosis. We're very careful to really try to identify depression that's been going on for a while, so it's not just an adjustment to having the acute medical problem, or that it is not just a bunch of physical symptoms associated with their medical problem, but actually is a sort of long-standing chronic illness that's been sort of confounding their medical treatment. You have to remember that there's some potential for spontaneous recovery. If you don't take people who have been depressed for a while, if people have only been feeling bad for a few days or even a week or two when their medical symptoms are worse, they might just get better on their own. And the other thing that we found was a real struggle is that if you start inpatient, those patients might go elsewhere. We had, in the Succeed and Mosaic studies, we had a patient in the Philippines. We had a patient in the UK. We had a patient in India. And so we actually had, a very wide-ranging collaborative care model, which actually can work. I mean, we actually were able to figure out the time differences and call them on the phone, and we actually were able to get a hold of their care providers there. But the point is, it makes coordinating, when your primary care doctor is in Manila, it makes it a little bit harder to get really tight collaboration, and so you have to do a little bit more. And finally, with the blended care implementation, you can have potentially such a greater impact on people's medical outcomes because your care manager is asking about blood pressure and weight and glucose and motivating them. But at the same time, you need to do even more training of your care manager to feel comfortable not just with the depression piece, but also with the medical outcomes. So, that was a lot of information in a short amount of time. Collaborative care works. It's good for depression, it's good for anxiety disorders, it helps people's quality of life, it helps people's function. It has now been studied in thousands and thousands of research patients, thousands and thousands of clinical patients. It really is, I think, the time has come for collaborative care. Some of the implementation models we talked about, like inpatient implementation and blended care, might provide an added boost by either getting higher yield patients or by doing more for them. But to be effective, I mean, these are the things we learned over 8 or 9 years about all of these very specific things that we talked about. You need to have a proactive and organized approach to both advocacy and developing your program, patient identification, and then following patients over time to make sure that it really works well. And having a program that specifically trains people to become good at collaborative care is a really good idea. It allows people to develop an expertise in this, which is not the kind of expertise that they've gotten in medical school or nursing school or social work training or those kinds of things. And with that, I just want to thank our whole cardiac psychiatry research program team for doing all of those studies and calling all of those patients and helping to track all this down. And with that, I will take questions.
So we have time for about 15 minutes of questions. So.
I have some comments.
Great.
It tickles me now that we're talking about the interface, psychiatry and cardiac disease. It reminds me of the study of Pratt in circulation in 1996. He was looking at the enteric-coated aspirin study, and these were patients who have never had any history of heart attack before. And they were actually reviewing risk factors. And they looked at hypertension and gender. And male to female odds ratio to develop heart attack was 1.75:1. For hypertension was 1.75:1. For patients who suffered from major depression, the risk for a heart attack was 4.6:1. Very high.
Yeah.
And this was way back in 1996. Now, the other thing that you mentioned, of course, starting off with just depression and then eliminating bipolar, I just want to sort of cite that eventually I think we will have to sort of include bipolar patients because we know that the age of onset of cardiovascular disease among bipolar patients is about 50 compared to major depression patients, which is about 60, as against the general population, which is about in their 70s. So in fact, the morbidity is higher among bipolar patients. And the prevalence of cardiovascular disease among bipolar patients is higher than unipolar patients and higher than the general population.
Yeah, yeah.
A third comment that I'd like to make is we appreciate more and more now actually the troika of not only having mood disorders like bipolar or depression, but how it is associated with metabolic illnesses. Diabetes and so on and so on, and hyperlipidemia.
Yep.
And so, in fact, Roger McIntyre, who is one of our big guns in psychiatry here, he talks about, and there are studies showing that, in fact, if you treat the patient's diabetes with Invokana, for example, in fact, it will also yield improvement in the mood state.
Yeah.
So I was asking him, when will the time come when we psychiatrists become we become more prospective in our management.
Yeah.
Just like when we managed GERD, we looked at 3 medications. So I'm saying if eventually, probably in the future, when we diagnose bipolar, we think about not only mood stabilizers, but we think about metformin and we think about statins. The final comment is making diagnosis in psychiatry. I know sometimes it can be difficult, and we just, even we are looking at the research domain criteria in the United States. We look at negative valences and positive valences and social and all these things, because we can, in fact, appreciate that psychiatric diagnosis can actually blur boundaries. But if, so in fact, when I consult, say, patients who have dual diagnosis, who are mentally challenged, and so, I might think that they have bipolar disorders, but in fact, it's just because of their clinical presentations that go beyond psychiatric diagnosis, and we, in fact, manage better their dysfunctionality. So those are just my comments.
Yeah, great. So stay up there for a minute, just because I want you had so many good comments. I want to make sure I hit them. The issue of the I think a couple of them that went together. The issue of depression is a good place to start, but at some point, what about bipolar disorder, schizophrenia? People with bipolar schizophrenia die 20 years younger than their people in the other population, not because of suicide, but because of cardiovascular illness and other medical illnesses. So there have now been a group of people who are actually looking at reverse collaborative care, where they actually will have patients in mental health clinics that take care of people with severe and persistent mental illness will actually have medical providers come in kind of a flipped way with the same kind of model, where the experts in mental illness will be taking care of the bipolar patients, but there's got to be a care manager who's helping to manage their glucose and all of those other things, because people are starting to realize that these cardiometabolic risk factors are the thing that's killing their patient. And so I agree, there's got to be some, whether it's the reverse model or whether it's our model, these patients with serious and persistent mental illness are going to get lost if they don't get some kind of collaborative care. I really like the comment about if you treat the patient's metabolic risk factors like diabetes, their depression gets better. I mean, it's funny. I was talking to a colleague, and he said, I had this patient who had treatment-resistant depression, and they got Zoloft, and then they got Cymbalta, and then they got this other thing, and then they got metformin, and then the depression got all better. It's almost like the secret antidepressant is treating their high blood glucose. And I think that we're coming to understand also that depression and metabolic disorders are both disorders of inflammation. They're both disorders that can be treated by things like exercise. And so I think the distinction, again, between mental health and medical health, the more we can get those things lumped together, I think the better. What was your fourth comment?
Oh, it's the research domain criteria in terms of making diagnoses.
Right. I mean, one of the complexities, and I think one of the hard parts about collaborative care is that it does, if done in the way that I described, it misses nuances. It is a very good way of taking care of a large population of patients in a way that is much better than probably any other way, but it does miss the nuances. And often, one thing that we try to train our care managers to do is to have their antenna up for something that seems a little bit weird, because sometimes a psychiatrist does need to get involved, or they may just need the psychiatrist to see them just the once or talk to them just the once to try to get the nuance, because doing just the PHQ-9 or having as opposed to somebody like you who's seen thousands and thousands and thousands of patients, there is a difference, and so it does miss the nuances, even though it's a really good model. So great comments, thank you.
Thank you.
Other questions?
He had like all of everybody's questions, all contained within himself.
Jeff, I was really interested in your training, and what struck me is when we were starting to conceptualize some of the training and education, we were maybe more on the skills building and thinking about maybe some common care pieces. And your training, when you conceptualize it, is really around, a lot of it anyway, is around the process. And it seems to me that it's tied very closely to the model that you're actually delivering.
Yeah.
So I'm just curious about to what extent you think we can develop maybe more generic education programs, and to what extent you have to be really targeted on what we're actually doing in terms of programs.
Yeah. I mean, I have a very specific opinion, which may not be everybody's opinion, but I feel like there have been so many attempts in large and small ways to increase the education of both mental health and general medical providers. And general education is helpful, and it gets things on people's radar, but it really over and over and over doesn't seem to improve patient outcomes. I think my sense is that rather than educating people generally about the importance of a biopsychosocial model or about patient psychosocial needs, to actually do education that's in the context of an effective treatment, I think is so important. And while it narrows the scope, I mean, if you teach people about sort of thinking more broadly psychosocially, that may help all of their patients. But it also, without sort of a good backup in treatment, it might help none of their patients. With something like this specific targeted model, I think if you can teach people about sort of a very specific way to think about providing care and to train them more in knowledge with regard to that kind of care, I think you actually see better patient outcomes. And so my feeling is more to really pick a model that you think is going to improve patient outcomes and almost work backwards from there and educate people within that context, though other people may disagree.
Other questions? Sorry, I'm looming in the back. For your programs, how did you ramp up education for your care managers?
Well, there's really two ways that we did. We didn't have a ton of care managers, so these programs are really small. I mean, so for example, we at most had 2 care managers at a time. But really what we did was, we did kind of the 3 things we talked about. One was that I did a lot of specific training about the diagnostic piece and about the model. The second thing was we wrote everything down. And the third thing was that you're actually, once your care managers get trained, they can do a lot of the training, and that's a very nice model because the care manager knows more than I do about, some of the very specific details that are the hardest part of their day. They're like, oh, good grief, this is the thing that's going to kill you if you don't remember this. And so it was very helpful to have that. And so I think however you want to conceptualize it, from some training from the leader of the program or the developer of the program, some written information, and then some peer-to-peer education, all ended up being important.
And I have one final question for me. You mentioned that obviously collaborative care and integrated care covers a population-based type of approach. What happens as you talk about the engagement of your primary care provider or specialist and you're treating depression? How do you maintain engagement when they have that difficult patient who has
Right.
schizophrenia plus alcohol use disorders plus something else that is they're struggling to find a way to help in that context, and then but the intervention is targeted towards, say, depression.
Yeah. So I think it's one of the important pieces of education with the primary care docs is to let them know what you kind of can and can't do, and for the things what you can't do, to figure out what you can do to help them. So whether that's actually, some of those cases are referrals to your outpatient colleagues, or whether there is some kind of community system or something. But I think it is really important education-wise, because they'll get really frustrated really fast if they're like, wait, I thought you were the psychiatric care team, and now this patient's driving me crazy and you're not going to take care of them? Like, what the heck's going on? And so to make sure that they know, okay, this is the depression care team, and they're the ones who are working in the clinic. And then if I have this other more complicated problem, then I refer here. And often what we would do was we would sort of be the conduit of that. And so the care manager would be would really try to take that off their plate. I think that's a very important liaison role. If the PCP was like, this patient is driving me bananas, the care manager would say, okay, we got this. And then we would in the kind of background figure out what we were going to do in terms of referral, and then go back to them. We still wanted them to feel like we were helping them, even if we weren't the people who were doing that piece. That's a very good point.
Any final questions? Last chance to have the last question. Okay.
Oh.
At the back, there we go.
For how long the case managers will follow this patient? How long will they be involved?
Yeah, I mean, as part of our programs, they followed them for 6 months. But, if this were like a clinical service line, you could imagine them following them for a long time. One important piece that I didn't talk about was a little bit about maintenance. So you'll have patients either because they've dropped out of treatment or because they've gotten better who will kind of go toward a less comprehensive model of monitoring. You're not going to call them every week, for example. And that's an important piece as your program starts to grow, because you can't just keep adding patients and start calling all the patients every single week. And so you do have to develop a model of kind of maintenance, and sometimes even people will step off the program for a period of time. Because especially if you have the screening going, they can step off the program, but then if their depression comes back, they can step back in. But it is important to have some kind of way to kind of slough off patients, because there are always going to be some coming in.
Well, thank you again.
Thank you, everyone.